So there are a bunch of different conditions. We could spend a week talking about ribs. I've already dealt with a lot of rib issues in previous videos. So I'm going to talk about a couple that aren't so common. Actually, these both occur from 20 to 40% of the population during their lifetime. So they're not totally uncommon, but they're also something that is commonly overlooked or misassessed. So basically, we said the first 7 ribs are the true ribs. These are false ribs, 8, 9, and 10. So I think we're going to deal first with slipping rib syndrome. It's got another name, and I don't know what it is, but that's where one of these bottom ribs, which is just cartilage, embedded basically in cartilage and fibrous material, gets caught up under the adjacent rib. You see that in people that have, posture issues and have some sort of sharp exhalation that will cause the rib to come back up and jam up under the adjacent superior rib. Tip syndrome. No, slipping rib syndrome. Sorry, we're going to do rib tip syndrome in a minute. This can be very painful. A lot of people have abdominal issues with it. It can also hurt in the back because also you have a couple of joints back here in the back, right? The costovertebral and costotransverse joints. And this thing gets jammed up under here. It can cause this one to pull out. And sometimes they both become fixated up too. So I'm going to show you a technique where you can get right on it. One of the ways that you identify it is it's going to be really absolutely tender to the touch. People will say, yeah, I hurt right here. And you push on it. But the problem is most people think that it's a problem that that the rib needs to come up. It does not need to come up. It needs to come down and out. And so one of the techniques obviously would be to be able to grasp that rib, both edges of that rib, and do a translation motion outward. So that's the first technique that we're going to do with the ribs. And then the other one that I'm going to show you is called rib tip syndrome. This is common in our elderly population, and it's really a painful thing. It's amazing when you see this much space because all this disc space, the lumbar vertebrae have so much disc space that it looks like, how could they ever touch? It's also called kissing rib syndrome, where it touches the iliac crest, the pelvis. So it drops down, they lose their height in here, they got no spring system left, all the discs are pretty much collapsed, and then they really notice it when they side bend to the ipsilateral side. They side bend to one side and it hurts on that side. That's one of the dead giveaways for it, and it's hurting right along the crest. It can also feel like a kidney problem, because obviously the kidneys are right under the 11th and 12th ribs, right? So another problem that can happen that I'm not going to deal with today, a fairly common one that Dr. Rolfe talked about, is when the 12th rib comes up under the 11th drops down, and it gets fixated like that. But basically what happens in this one is the costal cartilage gets weak, and they've lost all this disc height, and it starts to clip the crest of the ilium. Okay, come on in, Terry. Or come on over, I should say. You already are in. Thank you for helping us out, dear. Lie on your, let's see. Lie on your back, I think. No, lie on your left side. No, lie on your back. No, I'm kidding. Go on. All right, over this way. No, on your left side. I was kidding. Come on, on your left side. Get over here. There we go. Keep these knees bent. Always put something between your knees. There like that. All right. Get them square on the table where they're nice and straight on the table. All right, so first of all, we'll look at slipping rib syndrome. So I'm going to take this and have her put her hand behind her head here. The 11th, let's just say the 9th rib, which is a false rib because it attaches to cartilage and not to the costosternal joints like the first 7. It comes up, it slips under 8. It'll slip under 8. So right there, this is 9, this is 8, and it's going to slip right under there, and it's going to be very painful when I touch it. So I'll go 8, no pain. 9, pain. 10, no pain. Ticklish, no pain. Sorry. Well, that's one thing you got to deal with. By the way, have you ever tried patting them when they're ticklish? It gets rid of that. The mechanoreceptors start to pick that up. Okay, so what I'm going to do here is I'm going to try to drag that thing down, try to drag 8 out from under 9. So I'm coming in right on the superior border, and there's not much of a superior border. You've got to come in right here to catch it. I can't even catch it here because it's starting to dive up under 8. So right here, and then I'm just going to put a translatory and a rotational force through there. This finger is doing all the work, you okay? Mm-hmm. And then gently pull your elbow toward that direction, yeah, and relax. And I'm just kind of dragging this thing down. If it's real tender, just go easy. You might want to start, if it's really tender, you can start like this with a hand over grasping the top of the therapy table and coming in with a real gentle palm pressure, because sometimes this rib and back will be also jacked up at the costotransverse, costovertebral joints. So you get in with both hands, elbows out, body weight, where you're using your body weight. If breast tissue is ever an issue on any of these things, use a soft, a pillow of some kind, a small pillow like this, something like that. That's what the osteopaths do when we were going to Michigan State. All of the ladies that felt uncomfortable with that would use a pillow. Okay, so pull up on the therapy table and exhale at the same time. Exhale while you pull up. And relax. And pull up. Gently pull up on the therapy table and just relax the breathing. Go ahead, pull up. You can start with that. You can start by sometimes we did this in the first, in breathing and belly work too. Just come in like this and ask her to pull her elbow toward her hip, gently, 2, 3, 4, 5. And when she relaxes, I just pull the whole thing down. Why I don't like this right off the bat is because it's also pushing it in. So you're wanting to be able to, at some point during this session, to get hold of it and rotate it out. And it's easy to test because it won't be tender once you get it out. Sometimes it'll click when it comes out. That's not a joint popping. That's the fibrous material that's built up around the cartilage if it's been there for a while. All right. So that's slipping rib syndrome. Anything that's going to create space here is going to help. So I'm going to take Terry's leg off the table and let it hang off and get as much decompression going on here as possible so I don't have to work as hard, right? So this is coming off like that. And now I'm going to come down. Actually, put this custom craft table up. Grasp the sides of the waist. Again, if the breast tissue is an issue, use a pillow here. And come down and really let your body weight drop down into this, like this. And now, Terry, pull up on the therapy table. 2, and hold it. 2, 3, 4, 5. And when she relaxes, I'm going to pull it down. Trying to create space in here between the rib cage and the pelvic girdle. And again, pull up. 2, 3, 4, 5, and relax. And one more time. Up. 2, 3, 4, 5, and relax. Back to this position. Also, if your arms are long enough, you can come in like this. Get hold of the pelvis and do this. And get your body weight back. And now pull your elbow toward your hip gently. 2, 3, 4, 5, and relax. And then I try to separate get as much space between the shoulder girdle and the rib cage as possible. the rib cage and the pelvic girdle as possible. That's one thing we always do. We work the front, we work the back, but we don't work side lying enough. And so we're not getting this space. We're not getting this open on the sides, getting the brain to let some of that go. We've got to, it gets guarded in there, and we get slumped over with poor posture and get some iliopsoas, hypertonicity, stuff like that. I also like to come in with just a web. Some people's web is not, their hands are pretty small, so this webbing technique does not work, particularly on some people. Again, I'm going to come in with the same grip here, right here on the crest. And now, again, gently pull, 2, 3, 4, 5, and relax. So here, I'm actually pushing down right where, and back, this part of my index finger is right where that rib is nipping. That 12th rib's dropping down. And sometimes it's the 11th that drops all the way down, touches it. It's not the 12th. And relax, because it has obviously a longer head. They'll hurt more out to the side. Again, the assessment just includes palpating that area. When they go lateral and there's a pain on side bending in one spot laterally and you palpate it and it hurts, that's what's going on. Okay, one more time. 2, 3, 4, 5, and relax. Okay, and you've seen me do this quadratus lumborum technique a bunch, and you have your own quadratus lumborum techniques that you like, and really we're only affecting the quadratus lumborum, and really we're just asking the brain to allow this to open up. That's all this is doing, is teaching the brain that we want this decompressed. I do inversion every day, and I always try to get my clients doing some sort of inversion. Okay, I'm going to do a QL technique, and actually I'm going to come right to the very lateral edge of the hip here, and there's a little bitty divot where you can get in laterally. And if I could go straight down in there, this is a technique that Ida Rolf used to do. I never have done it with my fingers very successfully, but you can go in and you can start contacting those lateral fibers of quadratus lumborum, but you can't do it through all of the thoracolumbar fascia and then all of the muscles that attach to the pelvic brim down there. Remember, all of these muscles coming down here, all the erectors and all that stuff, are fighting for a place along the bony margins of the pelvis. Our job is to make sure they've got good mobility down here. So I'm going to come in with that elbow right here, and I'm going to ask Terry to, even though her leg's off the table a little bit, we're trying to get it as open as possible. I'm going to still ask for pelvic tilts, and I'm coming in with a sharp point of my olecranon, no forearm. It's got to be sharp, but you've got to be gentle with this too. Now, just slow pelvic tilts. Do just inhalation, exhalation. Forget the pelvic tilts. Mainly exhalation. Push it all out, just a little bit inhalation, mainly exhalation. And I'm just kind of dragging the tissue down. Any kind of movement enhancer you can put in there that helps you move along. You okay with this? Yeah, you all right? So going on down, and sometimes it takes a while to get down to where you want it to be. You're just meeting the restrictive barrier and trying to work right at that infield. You can feel it there? Mm-hmm. Okay, just a little bit more now, a little bit of pelvic tilting. Just a little bit. Mm-hmm. Just a tiny bit. That's good, yeah. Mm-hmm. So, rib tip syndrome and slipping rib syndrome, two that we typically do not do, but they're both assessed through palpation. So include those in the rib work that you do. Thanks.